Chapter 19, the quality control process. Controlling phase. The standard is predetermined level of excellence used as our guide, usually the minimal. We should strive to be above standards. Administration needs to be bought in, not just trying to obey the law. They should not just want the minimum done. On the basic steps for the quality control process. Basic steps is the criterion. What was expected? Information. Was it met? Educational. Was it done? When is it met? Development of standards. Predetermined level of excellence that serves as a guide for practice. Standards and policies must be measurable, which means objective, achievable. The faculty determines the standards, and these should encourage safe and effective care. The NAA scope and standard of practice. Assessment, diagnose, outcome identification, planning, implementation, evaluation. Let's see, which we don't have to memorize this. Excuse me. The National Guidelines Clearinghouse Key Components gives the most recent evidence-based practice, free database, and clinical practice guidelines. Which of the following would be a potential source data for a manager to assess quality control of a post-operative patient? And that is a physician orders, nursing notes, and post-operative flow sheet, which is all of the above answers. Also on the outcome audit, nursing sensitive outcomes separate out contributes of nursing to patient outcome. This includes fall rates, nosocomial infection, patient satisfaction, pressure ulcers, and restraint use. This is like the satisfactory stuff. On the process audit, all outcomes did everything possible, but the patient still dies. So you do everything you possibly can, but some still happens. On the process audit involves documentation, deals with something not documented that should have been. Example, every 4-hour vitals ordered but was only charted once a shift. Charts will be audited to make sure that standards have been met and orders have been carried out. To go back with the high quality of care, staff and managers must take the responsibility to stay current knowledge. What is the most updated evidence-based practice? This is hard to do with ever-changing technology. Okay. Let's see. What else? On post-operative, I might be jumping ahead here. Hold on. Yeah, I'm jumping ahead. On structure audit, structural audits assumes that a relationship exists between quality care and appropriate structure. Example is availability of fire extinguishers, staffing ratios, emergency department wait times, still patient safety focused, but specifically related to nursing. Also on the external impact on quality control, Medicaid, Medicare set some of the standards because they represent large groups. On the prospective payment system, payment is according to diagnosis, not length of stay or supplies use. Example, congestive heart failure has X amount that is reimbursable. This has led to dissatisfaction by nurses regarding the patient's quality of care. On Joint Commission, the initial core measures were MI, pregnancy-related issues, heart failures, and pneumonia. Now there are several more. Be very consistent. No one determines exactly what is being submitted. Different facilities are submitting info. Can't really be measured. Question: paying providers a fixed amount per patient admission regardless of actual cost to provide care is referred to as prospective payment system. The prospective payment system was the result of DRGs where the provider are paid a fixed amount per patient admission regardless of the actual cost of the providing care. In an ongoing problem, there is a threat to quality of care as far as various strategies, barcodes, medication reconciliation, smart pumps. It is no longer okay to write continue home meds. Now, medical doctor must write out meds. Also, 44,000 to 98,000 die from medical errors. On the leapfrog group, basically, we are doing what they recommend, evidence-based hospital referral. This would be like the small facilities that would want to treat high-risk patients. Now they are encouraged referral sooner rather than later to facilitate that the better outcomes are increased risk. Also, organizational reports, medical errors, they are protected because they voluntarily submit the info. These are the whistleblowers. On the leapfrog group, ICU doctors, staffing, MDs will be experienced in the critical care. Patients patients, MDs on staff will be an experienced, critical care person. Question: medical errors is the fourth leading cause of death in the United States. That is false. Medical errors is the eighth leading cause. And that was chapter 19.